I'm holding in my hands here a total hip replacement prosthesis, and shortly I'll explain exactly what a hip replacement is and answer all the common questions that you and your family might have about hip replacement surgery. Now, the aim of this video is to give you and your family a more realistic and practical understanding about hip replacement, so that you can make the best possible decisions for your hip. Now, this is a very comprehensive educational video, and as a result, it is quite long, but I do encourage you to watch it all the way through. It is vital that you understand as much as possible before considering hip replacement surgery. We also know that most patients will not remember all the information they are told by a doctor during the average consultation. The beauty of an educational product like this video is that if you do forget something, you can always come back and watch the video again to refresh your memory. I'd also suggest sharing this video with your family and friends. It will help them understand more about the decisions you are making and why you're making them. Just use this video as a guide, and at the end, jot down any remaining questions you have so that you can discuss them with your surgeon. The more you know and understand about hip replacement before you even see a surgeon, the more you'll take out of your consultation with them. I'm sure you can all relate to walking out of a doctor's office and thinking, I just knew there was something else I wanted to ask and I forgot about it. If you just write down the key questions you want answers to before you see your surgeon, then this won't happen. Your hip is a simple ball and socket joint. The socket of the joint is called the acetabulum. The top of your thigh bone or femur has a ball on top of it. It fits perfectly inside the socket. Now, many patients think that their hip joint is on the outside, but that's not actually true. The femur or thigh bone has a bony bump on the outside called the greater trochanter, and this is what you can feel on the outside of your hip. But that is not actually part of the hip joint. The ball and socket of your hip joint is actually located beneath your groin. If you pushed a pin through the skin of your groin, it would eventually pop into your hip joint. And this is why hip pain is commonly felt in the groin or the buttocks. Hip pain can also be referred down your thigh and even into your knee joint. Both surfaces of the ball and socket are covered in a smooth substance called articular cartilage. Now, my grandpa, back in the day, would have referred to this as gristle. You may have seen cartilage or gristle stuck to the end of a bone, such as a chicken wing. It's exactly the same substance that's in your joints. Now, this smooth articular cartilage allows your hip to glide around and move without any pain. A normal hip joint lets you move your leg in pretty much any direction, forwards, backwards, and also from side to side. These hip movements are essential for everyday activities, like doing the shopping, riding a bike, getting into and out of a car, and even putting on your shoes and socks. They all require your hip joint to move freely. The hip joint is right at the top of your entire lower limb, so every joint below also relies upon it. Otherwise, these joints have to compensate because your hip is not doing its usual job. The hip joint takes a huge amount of pressure off your lower back or lumbar spine. So if your hip is stiff and not moving properly, you may also experience worsening back pain. When the smooth articular cartilage of your hip joint wears away, it exposes the bare bone beneath. Your hip literally begins to grind bone on bone, a bit like a mortar and pestle that a chef would use to grind up spices, two very hard surfaces grinding together. Now, this process is what we commonly call arthritis. Now, arthritis is quite a complex and interesting topic in itself. So if you'd like to learn more about what causes arthritis and how it affects your joints, then take a look at my arthritis video on the education section of my website. When looking at an x-ray of a normal hip joint, we can see a clear dark space between the ball and socket. Now, that dark space is the cartilage inside the joint, which is invisible on an x-ray. When looking at an x-ray of an arthritic hip joint, we can see there is no longer any space between the ball and socket. The nice smooth contour of the joint has also changed. This is because all the cartilage has worn away and the ball and socket are now grinding together. The more bone and cartilage that grinds away, the more the ball will move deeper into the socket. This makes the entire leg shorter on that side. It's not uncommon for a patient's leg to actually be 1 to 2 centimetres shorter due to their hip arthritis. Because this shortening happens slowly over many years, most patients don't actually notice it, and they can be quite surprised when I point this out to them. An arthritic hip can be very painful, but that's only half the problem. As arthritis progresses, the hip joint also becomes very stiff, and this has a big impact on your function. Remember, you need your hip to move freely to let your lumbar spine and other joints in your lower limb do their jobs properly. And that's why hip arthritis can be so disabling. It's not just pain, the stiffness of your hip prevents you from doing a large number of activities. Some of the common problems patients report include difficulty bending down to pick things off the floor, getting into and out of a car, and especially getting dressed and pulling on their shoes and socks. Hobbies like playing golf or going for a walk are also very challenging. Pain is also a major symptom, and if severe, it can actually make everyday life quite miserable. A loss of sleep and a need to take regular pain medications is very common. A hip replacement really has two main goals. Number one, to take away the pain and inflammation from your bones grinding on each other by allowing your joint to glide smoothly. And secondly, to improve the range of motion of your hip so that you can perform the activities you need to. So, what actually is a hip replacement? In simple terms, it involves giving you a new ball and a new socket. The first thing we do is to remove the old, worn out or rusty ball of the hip joint. Now this does require a surgeon to make a cut through the bone with a small saw. We remove the ball and also a few millimetres of bone from what we call the neck of the hip joint. That's this bone in here. So after we've removed the rusty ball and some of the neck of the hip joint, your thigh bone looks a little bit like this. You can see how there's no longer a ball or neck on top of it. Now as you might know, the inside of our bones are hollow, and we take advantage of this hollow cavity inside the bone and we place a metal prosthesis down inside it, just like that. So now that metal prosthesis is sitting nice and securely inside the thigh bone. Now the prosthesis that goes down inside your thigh bone is actually made of metal. But on the outside it's got a very special rough coating, and this does two things. The first thing is it's very grippy, and as it goes inside the thigh bone it grips very tightly, so as soon as your prosthesis is inserted, it's strong enough to walk on. The second function of this rough coating, which is very clever, is it enables bone to grow into it. It's exactly the same size and shape of natural bone, and so by about 6 weeks after your surgery, your human bone has grown into this prosthesis and securely glued it inside your thigh bone very naturally. In some patients, your surgeon may choose to use a special bone cement, and that securely cements the prosthesis inside your thigh bone. So now the prosthesis is securely fixed inside the thigh bone. The next thing we do is place a very smooth, beautiful round ball on top of the prosthesis like that, and it fits securely in place. And this becomes the new ball of your ball and socket joint. Now this particular ball is made of ceramic, but they can also be made of metal. So now we've taken away your old, rusty arthritic ball and given you a nice, shiny, brand new one. Now the socket of your hip joint, which we call the acetabulum, is located up here inside your pelvis. So the next part of the procedure involves inserting this metal prosthetic socket into the arthritic socket of your pelvis. Now this artificial socket is made of a similar metal as your thigh bone prosthesis. It also has the same rough coating on the outside that is very grippy, and that makes it stick inside your pelvis as soon as we place it there. Your bone will also grow into this prosthesis and naturally heal it in place by about 6 weeks. So after the metal socket is positioned, we then place a very smooth, shiny piece of plastic inside to the cup like that. Now what this does is act like the artificial cartilage inside your hip joint. Now this is a very hard-wearing medical grade plastic, and the technical name is high molecular weight polyethylene. But look, don't worry too much about all the technical terms. Just think of this smooth lining inside the socket as acting like the non-stick Teflon in your fry pan. But sometimes this lining can also be made of ceramic, just like the ball of the hip joint is. So unlike before, when your arthritic hip was bone grinding on bone, you now have these two beautifully smooth surfaces that can glide over each other. Now this is what takes away your pain and also improves the range of motion of your hip joint. When we look at an X-ray after a hip replacement, you can see the new socket, the new ball, and the prosthesis inside the thigh bone. Of course, what we can't see is all the muscles, tendons and ligaments around the hip joint, because they are all invisible on an X-ray. Because we are actually replacing the bone and cartilage that has worn away from arthritis, a hip replacement is also able to lengthen your shortened leg and put it back to the same length as it was before arthritis shortened it. Some of my patients are confused about how their hip joint should actually be replaced. There is a lot of information available about hip replacement surgery, with varying opinions about what is best. Now each surgeon has a particular preference and skill set for the type of procedure they use to replace a hip joint. This might be influenced by where in the world we completed our training, what surgical techniques we've been exposed to, and also what the evidence tells us works best for patients. Now every hip replacement technique does have pros and cons, so talk to your surgeon about why they prefer the particular technique that they use. It's also very important for me to highlight that no matter what technique a surgeon uses, a hip replacement is an excellent operation with very high levels of patient satisfaction and function. In fact, a number of studies have shown that no other operation in the world improves a patient's quality of life as much as a hip replacement. It's been an incredibly successful procedure for many years. There are three main techniques that a surgeon can use to replace your hip joint. We can replace your hip through the front, or the anterior approach, the back, or the posterior approach, or the side, which is called the lateral approach. Now you can think of each of these three approaches as being a different door to your hip joint. Each door leads to the very same place, just through a different path. The posterior approach, as the name suggests, replaces your hip through your bottom muscles. A surgeon separates the largest muscle in your body, called the gluteus maximus, and that is located just under the skin of your buttocks. The surgeon then detaches some tendons around the bone of your hip to expose and replace the joint. At the end of the operation, these tendons are repaired back to the bone with suture material. The gluteus maximus muscle is also repaired back together with sutures. Personally, I only use the posterior approach in a small number of specific patients. However, many surgeons do use this approach for all their patients, and the outcomes are very good. The lateral approach involves detaching part of a tendon, called the gluteus medius tendon, from the thigh bone. Now, gluteus medius is one of the most important muscles and tendons around your hip joint. Once the hip is replaced, the gluteus medius tendon is then repaired back to the bone with suture material. I don't use the lateral approach in any of my patients. The direct anterior approach, which is a technique I prefer to use for the vast majority of my patients, takes place through the front of your hip joint. The size of the incision depends a little bit on the size of a patient, but in general it's quite small, about 6 to 10 centimetres in length. Rather than splitting muscles or cutting through tendons, we move in between the muscles on the front of the hip to gain access and replace the joint. At the end of the procedure, no muscles or tendons require repairing with suture because they have not been cut during the operation. The principle of the anterior approach is to allow patients to mobilise more quickly with less pain and weakness early after the operation. Temporary weakness is created when a muscle or tendon is cut until they heal and recover. It's for these reasons that I'm so passionate about the anterior approach for my patients, because it avoids cutting muscles and tendons. But again, I would stress that all hip replacement approaches give excellent results in the longer term. The most important thing isn't what approach your surgeon uses, it's their skill and experience with whatever technique they are comfortable with. So you need to make a choice about what is best for you and your hip. Most patients will spend 3 to 5 nights in hospital after a hip replacement. The high majority of my patients choose to go straight home after their stay in hospital. And actually, the safest place for most patients to recover from their surgery is in their own home. If you have specific health needs or just require a little bit more support, then you have the option of an extended period of rehabilitation within a hospital. Now, our nursing and physiotherapy staff at SportsMed are absolutely incredible. Everyone is specifically trained and very experienced in helping you to recover from joint surgery. Every patient has a private room, ensuite and free Wi-Fi. And patients also tell me they love the food. There is a reason SportsMed has twice been rated the #1 private hospital in Australia. And so many of my patients tell me about the really positive experience they had at SportsMed. You're allowed to stand up and walk on your new hip as soon as your pain control and strength allows you to do so. Most patients will aim to sit out of bed and stand on their new hip the very same day as surgery. A physiotherapist will work with you every day in hospital to get you up and moving, and also to provide a basic game plan for your rehabilitation in the weeks after you leave hospital. Rehabilitation begins from the very same day as your surgery. Unlike a knee replacement, where patients have to work quite hard to recover, anterior hip replacement is easier to recover from, and in general, you don't have to do a huge amount of exercises. I tell my patients the best thing they can do for the first 6 weeks after surgery is just gently increase their activity levels as they feel comfortable. More elderly patients will require the use of a frame for the first few days after surgery, but younger patients will typically just require a walking stick. It is uncommon for a patient to be using more than a walking stick on discharge from hospital, but occasionally this is required. After anterior hip replacement surgery, most patients are actually in less overall pain when they leave hospital than they were prior to surgery. Of course, they still do have some pain and swelling from the operation, but the severe groin and buttocks pain goes away very quickly. Patients will also notice more freedom of movement in their hip joint quite quickly. Many patients will describe a woody or bruise feeling in their thigh for the first 2 to 4 weeks after surgery. It can feel tight, swollen, and a little bit like having a corky from a bad knock playing sport. Now, this is very normal. Even though no muscles have been cut, you've still had a significant operation which involved removing the ball of your hip joint. There will be some ongoing bleeding and swelling within your hip for several days. And when you stand up, gravity allows this swelling to drain into your thigh and it feels swollen. Your body will absorb this over the next few weeks. The golden rule that I tell all of my patients is just to be sensible for the first 6 weeks after surgery. Some patients feel so good so quickly after anterior hip replacement that they can push things a little too far too soon. It does take 6 weeks for the prosthesis to heal securely into your bones, so there is no running, jumping, or high-risk activities during this time. However, the movement restrictions that may apply for the first 6 to 8 weeks with other hip replacement techniques are not needed after anterior hip replacement surgery. So you don't need to sleep on your back for 6 weeks. You can sleep on your side immediately if you wish. You do not need to sleep with a pillow between your legs, and you can usually drive a car within 4 weeks of surgery, but this does vary from patient to patient. You need to have good strength, well-controlled pain, and no restriction of movement before driving. Your physiotherapist can help monitor this. One of the risks of any hip replacement procedure is dislocation of the ball from the socket, but the risk of dislocation is lowest with anterior hip replacement compared with other approaches that we discussed. For this reason, we can be more proactive with rehabilitation and get you moving quite quickly. You will also require regular, simple medication, such as Panadol and anti-inflammatories, for a minimum of 2 weeks, and possibly longer. If you still have pain despite these simple medications, you will have a supply of stronger pain medication to take if and when required. We call this breakthrough pain relief. If your pain breaks through the simple medications, you have a safety net of stronger medication ready to help. Most occupations will require 4 weeks off work completely, but a return to light or office duties could potentially occur from 2 to 4 weeks, depending on your job. Returning to manual duties would be a minimum of 6 to 8 weeks after surgery, and possibly longer, depending on your occupation. By 6 weeks after surgery, the majority of patients are walking normally and not using a walking stick. It is unusual for patients to be taking any pain medication at this time. By 3 months, the majority of patients will be over 80% recovered and back into all usual activities. The final 20% of your recovery occurs slowly but gradually from 3 months after surgery. You can have continued improvement for up to 6 to 12 months after surgery. I tell my patients that during this period, they'll become more accustomed to their new hip and most of the little niggles will slowly fade away. Don't forget, we have only replaced the arthritic surfaces of your joint. Everything else in and around your hip joint is the same age as you are. Whilst we can expect a smooth and pain-free joint surface, we can't expect all your muscles, tendons and ligaments to feel like you're 18 again. Now, I'll do everything I possibly can to give you the best result, but sadly, I can't make you or your hip muscles any younger. I wouldn't recommend that a patient runs after having a hip replacement, as this will make your new hip wear out more quickly. But you can walk, swim, hike, ride a bike, go to the gym, and pretty much build back into most of your regular activities. Playing golf, lawn bowls, and even a social hit of tennis is possible for most patients. Like all operations, there are some risks that every patient needs to be aware of and understand. Serious complications are rare, but some minor complications are more common, and I'll point each of these out to you as we go along. All patients will have some degree of mild, ongoing bleeding and oozing inside their hip for several days after surgery. This is one of the reasons your thigh will be swollen. It is unusual for a patient to require a blood transfusion, but sometimes that is necessary. Injury to a major blood vessel is a very rare complication, but if it did happen, you may require additional surgery to repair that blood vessel. Damage to a major nerve is also very rare, but if that occurred, you could be left with some permanent weakness. Infection is thankfully a rare complication, occurring in less than 1% of patients. Infection with the anterior approach is actually lower than with any other hip replacement approach. If you do have a deep infection inside your joint, it can be challenging to treat. It will require further surgery to wash out the infection, several weeks of antibiotics, and sometimes a number of operations to remove the infected prosthesis and replace it with a new one. You'll be given antibiotics via a drip before and after your surgery to reduce the risk of an infection. You will also be given a scrub brush of antiseptic solution to wash your entire body with prior to surgery. I recommend the use of an antibacterial nasal ointment in the 5 days before joint replacement surgery. Your nose is a major reservoir of bacteria that can cause joint infections. By using the ointment, we reduce the number of these bacteria, and some studies indicate this may reduce the risk of an infection ever occurring in your hip replacement. It is very common for patients to describe a feeling of numbness on the outside of their thigh. This is because there is a network of fine sensory nerves just beneath the skin, very close to the location of your surgery. Now, these nerves can be damaged by being cut or stretched, or even just irritated from swelling. This numbness usually resolves, but it may take 3 to 6 months or more for this to occur. In some patients, numbness may be permanent. This would not affect your movement, but it may irritate your skin, and some patients find the feeling uncomfortable. You will be given medication after your surgery to gently thin your blood to reduce the risk of you forming a blood clot in your calf, otherwise known as a DVT. Now, a blood clot in your calf in itself is not dangerous, and your body will slowly dissolve the clot. However, if the blood clot travelled from your calf up into your lungs, it could make you very unwell or even be fatal. This situation is fortunately very uncommon. We monitor you closely for signs or symptoms of this during your recovery after surgery. An artificial hip joint is not as stable as your natural hip joint, and it is possible for a hip replacement to dislocate. Now, this simply means that the ball pops out of the socket. One of the many reasons that I prefer the anterior approach for my patients is the risk of dislocation is lower than with other approaches. The risk of dislocation is about 1%. If your hip did dislocate, you would need to have it manipulated back into place under anaesthesia. If it continued to dislocate, you may require revision surgery to prevent this happening again. A major fracture of the thigh bone, or the bony socket of your hip joint, is a rare complication, occurring in about 1% of patients. The risk of this occurring is slightly higher with the anterior approach than other approaches. This can occur during the operation or in the weeks and months after surgery. If this occurred, you may require further surgery to fix the fracture and replace the hip joint, or a slower recovery period to allow the fracture to heal. A hip replacement can make your leg longer or shorter. In general, we aim to equalise your leg lengths so they're about the same on both sides. But the most important factor is that your hip joint is stable and does not dislocate. The muscles around your hip joint are a bit like elastic bands, and when they are placed under some tension, they keep the hip snugly in place. Sometimes, a surgeon may need to make the leg slightly longer to increase the tension of these muscles and stabilise the joint. If there is a 1 centimetre or less difference in your leg lengths, then most patients are very unlikely to even notice a difference. If it is greater than this, you may notice it, but wearing an orthotic within your shoe on the other side is usually enough to make a patient's leg lengths feel equal. One of the most common questions patients ask me is how long will my hip replacement last? The basic rule of thumb with a hip replacement is that it will last most patients 20 years or more. To put this into context, if we looked at every patient in Australia who had a hip replacement 18 years ago, over 90% have not required that hip to be replaced. If and when your hip does wear out, it can be replaced with a new one, but that surgery is more complex and the functional results may not be as good as the original procedure. Now, there is no definitive line in the sand for how old you have to be before you can have a hip replacement. Some young patients are suitable candidates if non-operative management of their pain has failed and their symptoms are severe. However, hip replacements don't last as long in younger patients as they do in more elderly patients. And this is because younger patients are more active and quite literally wear them out more quickly. Having said that, hip replacement technology has improved significantly, and the overall rate of hip replacements that are requiring revision surgery in Australia is continuing to decrease over time. Increasing pain and a lack of function are the two biggest reasons that you may need to consider having a hip replacement. Some patients will be able to manage quite well with pain relief, physiotherapy, and some natural supplements. The GLAD program, for example, is a specific physiotherapy program for patients with hip and knee arthritis symptoms. It aims to help patients reduce their pain and increase strength and mobility. It's worth speaking to your physiotherapist about this. The decision about when is the right time for a hip replacement is a complex and personal one. However, I would strongly encourage you to make a decision based largely on your level of pain and loss of function. Or put simply, how badly is your hip affecting your quality of life? You simply do not need a hip replacement just because an X-ray or MRI scan shows that you have arthritis. Many patients have arthritis, but their symptoms are quite mild. There is also no rush to have a hip replacement. You have plenty of time to think about your options and try alternative treatments. However, over time, arthritis symptoms do worsen as your joint continues to wear out. Unfortunately, we can't permanently cure arthritis without a joint replacement procedure. Getting a broad range of opinions from healthcare professionals is also helpful. Your general practitioner and physiotherapist are great sounding boards. They are people you know and trust, and they also know you and your health history. In my experience, most patients have told me that they eventually reached a point where they just knew it was the right time for them to have a hip replacement. Ultimately, this is a personal decision for you to make. So thanks for sticking with me through what I know was a long and information-rich video. But I do hope that this has given you a comprehensive understanding about hip replacement surgery and that it helps you in your decision making. Remember, if you have any specific questions arising from this video, then please do write them down. You can discuss them with your surgeon when you next meet with them. If you would like to talk to me about your hip, then please ring my rooms at any time to make an appointment. If you haven't already had appropriate scans, I can arrange for these to occur before I see you.